Hello, and welcome to the Minnesota Reflux and Heartburn Center. I'm Dr. Paul Severson, the director of the center, and I invite you to meet our talented team of experts to learn more as you explore our informational series on reflux, heartburn, and esophageal disorders. While dedicated to the treatment of reflux since the 1990s, the Minnesota Reflux and Heartburn Center was officially launched in 2015, and it's a joint partnership between two healthcare systems in central Minnesota, Cuyuna Regional Medical Center in Crosby and Riverwood Healthcare in Aitkin. As Minnesota's first center dedicated specifically to the disease known as Gerd, Gastroesophageal reflux disease, we have grown dramatically, and we're pleased to show you the comprehensive nature of our diagnostic and therapeutic center through this informational video series. Welcome.
I would like to welcome you to the Minnesota Reflux and Heartburn Center. I'm Leah Carlson. I am the program director and the patient clinical navigator at the Cuyuna Regional Medical Center location. I'm glad you could join us. The patient experience at the Minnesota Reflux and Heartburn Center would typically begin with an initial intake conversation with the clinical patient navigator to explore the patient's perspective of their symptoms. The comprehensive nature of an evaluation at the Reflux Center may be very different from what patients have encountered in the past, and we feel it's important for them to have a full understanding of what to expect and how to prepare for the evaluation. Most evaluations are completed within one day, consisting of consultation with a reflux specialist and the initial diagnostic panel of esophageal motility study, EGD, and a pH evaluation. And all the services are provided at the same campus with reflux dedicated team members. Our goal is to support patients in making informed decisions regarding their health based on clear and accurate clinical information. And now it is my pleasure to introduce Dawn Harsey, the patient care navigator at the Riverwood Healthcare location.
Hi, I am Dawn Harsey, registered nurse, clinical navigator here at the Minnesota Reflux and Heartburn Center. Today I'm going to walk you through our intake process. As the first point of contact for those with reflux and heartburn symptoms, we help make the intake process simple and easy. We will meet with the patient on the phone, in person, or virtually to discuss their reflux symptoms and review their history. Each patient receives an individualized plan of care. Patients are often scheduled with a reflux specialist for a consultation and a comprehensive reflux evaluation. We strive to assure the diagnostic and treatment process is comfortable and convenient for the patients and their families. We are the point of contact throughout the evaluation process and beyond. We invite you to give us a call today to discuss your reflux symptoms so you can enjoy living life again.
Hi, I'm Dr. Howard McAllister. I'm one of the reflux specialists at the Minnesota Reflux and Heartburn Center. My talk today is going to be a brief introduction to gastroesophageal reflux disease, some of its symptoms, and some of the impact that it has on the population of the United States. Let's talk a little bit about the general prevalence of gastroesophageal reflux disease and some of the effect that it has in the United States. We see this as being prevalent in about 10% of the Western population of the world, and that represents about 100 million people. It's the leading diagnosis in most outpatient clinics. It costs us over $9 billion in annual costs in the United States alone. It's a significant contributor to absenteeism and reduced productivity in the workplace. And most alarming of all is that it causes cancer. We've seen over the last 30 years about a 717% increase in the incidence of esophageal adenocarcinoma. That's a nasty disease, and it's one that we want to do everything we can do to prevent.
Gastroesophageal reflux disease, or GERD, is a condition that causes the burning sensation known as heartburn. When you swallow, food passes down your throat and through your esophagus or food tube to your stomach. A muscle called the lower esophageal sphincter controls the opening between the esophagus and the stomach. This muscle remains tightly closed except when you swallow food. When the sphincter fails to close, the acid-containing contents of the stomach can travel back up into the esophagus. This backward movement is called reflux. When stomach acid enters the lower part of the esophagus, it can produce a burning sensation commonly referred to as heartburn.
The lower esophageal sphincter is a ring of muscle at the end of the esophagus whose job it is to squeeze tightly enough that it pinches off the esophagus from the stomach in order to keep stomach acid and digestive enzymes out of the esophagus. That's important because while the stomach has a lining that allows it to protect itself from those acids, the esophagus has a different kind of lining and it can't. If that sphincter valve weakens or fails over time, bad things can happen in the lower esophagus as a result of the damage that it causes. That can be classic disabling heartburn, but several other issues can occur as a result of that reflux, and I'm going to touch on those in a moment. We estimate that there are about 20 million people in the United States who are taking powerful drugs like Prilosec in an effort to try to control their reflux symptoms. This is even more prevalent now that these drugs are available over the counter. You can see how common the reflux problem is in the United States by noting that even convenience stores, gas stations, have them on the rack. Of that 20 million people, about 60 to 70% find that those medications work pretty well to control their symptoms. But another 30 to 40% that take those drugs find that although it might improve the symptoms, it doesn't really control them to their satisfaction. They are the so-called walking wounded of the reflux world. The medication just doesn't work as well as they would like. They have to make other compromises in their life, usually in relationship to the foods that they eat, in order to keep their reflux from ruling their life. At the end of that scale, there are the people whose symptoms are so intrusive and so poorly managed by medication that they end up requiring surgery in order to restore that reflux barrier and control their reflux disease. So we have the people, about 60 to 70% of reflux sufferers, for whom at least for a while, the medication controls the symptoms to their satisfaction. And on the other end, we have the 1% or so of reflux sufferers who have had their reflux disease well controlled by surgery. In the middle here, about 30 to 40% of that Gerd population are the people who continue to have gastroesophageal reflux symptoms that rule their lives. This is where today's well-trained and knowledgeable reflux specialists, such as we have here at Minnesota Reflux and Heartburn Center, try to focus our efforts, controlling the reflux symptoms in people who otherwise have poorly controlled gastroesophageal reflux disease. Despite the medications, it continues to rule their lives, and we want to help those people. As I mentioned, the body has a natural barrier whose job it is to stop stomach acids from refluxing back into the esophagus. That has two components, the lower esophageal sphincter and the supporting pressure from the opening in the diaphragm that the esophagus goes through on its way to the stomach. That's called the esophageal hiatus. Reflux occurs when either or both of these two components are too weak, working together to keep stomach acids in the stomach where they belong. The weak sphincter muscle is easy to understand, but let me take a moment to explain hiatus hernia. That's a condition where the opening of the diaphragm weakens to the point where it no longer can keep the stomach completely in the abdominal cavity, and part of it slips upward inside the chest. That's a very common problem. Many people have hiatus hernia, but the problem comes in when that lower esophageal sphincter valve is displaced upward too. In many cases, that will further impair the ability of the lower esophageal sphincter to do its job, and it will prevent people from keeping stomach contents in the stomach. That reflux then can represent the symptoms of reflux disease. The question, I guess, that we always ask is, why is the lower esophageal sphincter weak? Why does that reflux barrier fail? Well, it does run in families. There's no question. We see this in families. The lower esophageal sphincter shortens over time, and especially with a full stomach, obesity, and pregnancy. The lower esophageal sphincter can weaken over time as we age, so this is a more common problem as we get older. And there are a number of drug effects and other things in our diet, such as alcohol, nicotine, and caffeine, that are going to loosen up that reflux barrier as well and allow reflux. There is, as I mentioned, an association with hiatal hernias. We also see genetic defects in the musculature and the muscle barrier that keeps the anatomy where it belongs. This is oftentimes due to deficient collagen cross-linking, which is part of the aging process. There are a number of symptoms of GERD, but it's important to note that only about 40 to 50% of people with significant reflux disease actually have heartburn as their primary symptom. The rest of the people can have a wide constellation and combination of symptoms. GERD may cause such severe chest pain as to mimic a heart attack. In fact, about 30% of emergency room visits for chest pain are due to the symptoms of GERD. But people will also complain of regurgitation at night. They oftentimes wake up bolt upright as stomach contents are coming back into the back of their throat, giving them a sensation that they can't breathe. We see that that reflux can go so far up the esophagus it can actually hit the vocal cords and cause hoarseness and voice changes. We note that there is a constant problem with epigastric pain, and that's kind of the hallmark here. Also, chest pain, as I mentioned, is a serious issue. Patients can have chronic coughing, and this can seriously impair their life. They have a sore throat oftentimes. There's constant throat clearing that a lot of these people have. They may have difficulty swallowing and choking, especially with things like pills. And they may have sinus symptoms, such as problems with recurring sinus infections. There are a number of other associated comorbidities that can go along with this, things like weight loss because of the changes in diet. They're just things that you just cannot eat. Oftentimes a bitter or bile taste in the mouth. Asthma is very commonly associated with reflux disease. You can get recurrent pneumonias because sometimes that refluxate that comes out of the stomach into the esophagus can be aspirated into the lungs. And that can also cause chronic bronchitis. It can cause dental problems. It can cause bad breath. Because of air swallowing that goes along with the discomfort, people will oftentimes have excessive belching and bloating. They'll oftentimes complain of a lump in the throat. And this can also be frequently associated with nausea and vomiting.
Hello, my name is Dr. Andrew Lovett. I'm one of the surgeons at the Minnesota Reflux and Heartburn Center, and it's my pleasure to talk to you about the complications of gastroesophageal reflux disease. We know from discussions with our patients and practitioners that GERD can significantly affect our patients' quality of life. It often leads to poor quality of sleep, reduced work productivity, and dietary compromises to avoid symptoms. There's also concern for the lifetime consequences of GERD, including the long-term effects of GERD medications. Long-term complications from GERD can cause changes at the lower end of your esophagus. In this slide, you see images of severe erosive esophagitis or inflammation of the lower esophagus and strictures or scarring. This can lead to trouble swallowing over time. One of the most concerning findings we find with gastroesophageal reflux disease is the development of Barrett's esophagus. This is a precancerous lining that develops over time to combat the symptoms of gastroesophageal reflux disease. It's caused by chronic exposure to stomach contents. This will occur in up to 15% of people with gastroesophageal reflux disease, and unfortunately can often blunt the symptoms so that they think the reflux disease has gone away. This does lead to up to a 40% time risk of esophageal cancer and is responsible for the 717% increase in esophageal cancer we've seen in recent studies. The key to managing Barrett's esophagus is to first identify it and then monitor it and hopefully eradicate it using techniques such as ablation or simply burning that portion of the liner away. We'd like to establish this before it turns to cancer. Esophageal cancer is the most dreaded outcome of gastroesophageal reflux disease. It's the sixth most common cause of cancer death worldwide, and there's an estimated 20,000 new cases in the U.S. every year alone. We've seen a dramatic rise in this cancer over the last 25 years, up to 717%. The reasons behind that are unclear. On this slide, you can see the epidemic of esophageal cancer. This graph portrays the epidemic over the course of the last 40 years. You can see that many cancers have been reasonably well controlled, and in fact, we've made some progress with most of them. Esophageal cancer, on the other hand, has had an exponential rise, almost 720% over the course of the last 40 years. Thankfully, you can see over the last decade, this is starting to level out. However, the mechanisms and causes behind this are still unclear.
My name is Melissa Deardahl. I'm the nurse practitioner for the Minnesota Reflux and Heartburn Center. I'm also the GI director for the center. Today I'll be walking you through a comprehensive reflux evaluation and the diagnostics that go along with that. Evaluating reflux disease. Comprehensive diagnostic evaluation is what's done at Minnesota Reflux and Heartburn Center. Starts with an endoscopy, EGD or upper endoscopy. This is to visually observe the esophagus, stomach, and duodenum. I kind of tell people this is where we look for the lumps and bumps, hernias, ulcers, strictures, those types of things. What we do during the EGD at our center, narrowband imaging, high-resolution detection of Barrett's esophagus. These are special lights built within the scopes. Triple biopsies are completed. Stomach biopsies for Helicobacter pylori, which is a bacteria that causes ulcers. Also for atrophic gastritis. Esophageal biopsies for eosinophilic esophagitis, which I like to say can be caused by reflux and sometimes can be the same as what asthma is to the lungs. It's an inflammation process within your esophagus. Biopsies of the gastroesophageal junction where Barrett's begins. Also completed is Bravo, which is an ambulatory pH monitoring system. This tests for acid reflux. Typically it's a 48-hour test in which we're watching to see well, first of all, if you have reflux, and then what is the severity and the pattern? Is it upright, supine, basically daytime, nighttime, or all the time? Some additional things that might be done during the EGD are Watt's 3D brush biopsy. This is wide-angle transepithelial sampling. This is a brush that instead of just biopsies, which is the gold standard in the United States. And to us, this is like plucking 4 pieces of grass out of a football field. We want to get the whole field, so the Watt's 3D brush biopsy is that. Stelvizio can be used. This confocal laser endomicroscopy. It's the world's smallest microscope that is, actually they can use it right at the time of endoscopy. So if they have any concern of anything that they're looking at, they can just put it down and look into your cells at that time. Balloon distension study, which is also known as the EndoFlip, is an endoluminal functional lumen imaging probe. This is a balloon with computer sensors that gives us real-time view of the esophageal function, precisely measures diameter and pressures within the esophagus. Esophageal manometry, also known as high-resolution manometry or HRM, this evaluates your swallowing ability. So basically the peristalsis of your esophagus or squeezer. Detects esophageal motility disorders because sometimes people don't have reflux, they actually have a motility disorder. It's an essential test to evaluate for difficulty swallowing, chest pain, and just for reflux in general, as it helps guide our treatment plan for you based on the performance of your esophagus. And just like it said. And again, this is, at our center, it's required before any anti-reflux procedure can be proposed so that we know we are giving you the best and safest option. Additional tests that might be recommended, additional pH testing. So sometimes that 48-hour test doesn't give us the information that we need, particularly when it comes to LPR type stuff, which is throat clearing, cough, voice hoarseness, all those types of things. So sometimes if people have had altered anatomy, such as a gastric bypass, we use a 24-hour pH impedance monitoring system. This is hardwired, so it is not a wireless system like the Bravo. And it's up to 24 hours. You can do it up to 48 hours, but oftentimes it's hard because it is a little catheter that will be coming out of your nose and taped to you for 24 hours. ResTech, oral pharyngeal pH monitoring system. This is another hardwired catheter, so you will leave with a little catheter coming out of your nose and taped to the side of your cheek. And this is again for kind of that cough, more throat type stuff. Patients will also often talk about abdominal bloating, early satiety, which just means you feel full very quickly after just a bite or two, sometimes after eating nausea, which is called postprandial nausea. So we will look at something called a nuclear medicine gastric emptying study. So this evaluates for gastroparesis, which is a weak stomach. It's not emptying correctly. 4-hour radiology study, I usually tell people bring a book, bring a friend, bring something because you're going to be there for 4 hours. It's an easy test. It's just x-ray pictures. So there's no tubes or needles or catheters or anything like that. The stomach is scanned. You get what they tell me, a delicious meal that's dunked in barium. So it's usually toast and eggs and things like this. So they'll have you eat that, and then again, every hour for 4 hours, they will take a picture of your stomach. Marshmallow bagel or timed barium swallow, those are both additional tests that again don't require any tubes, catheters, needles, anything like that. They're simply tests that you get to eat a bite of a marshmallow and a bagel. Again, it is dipped in barium. They take pictures in x-ray to watch that go down. Timed barium swallow is the same. You'll drink something, but they'll also give you a little pill or capsule with some barium to see how that goes down through. Upper GI with small bowel follow through, that's also an x-ray test. Basically the same thing, you drink barium, but they'll watch it go down through your esophagus, stomach, and into your small bowels. So just kind of watching for flow there, and if there's any obstruction or hang-ups, things like that. CT scan of the chest and abdomen. All these are really, they're tests that don't require any tubes, needles, catheters, things like that. They're pretty simple tests. Most of them are just time. Ultrasound and Hiatus scan for possible gallbladder disease. It is, I will say, often that people can have both. The symptoms are sometimes the same, epigastric pain or pain that kind of radiates off to your right side, sometimes left side too. So this is another additional test that we may do. Smart pill evaluates transit time through the entire gut. It's a little capsule that you swallow, and it tells us about your stomach emptying, small bowel emptying, and colon emptying, so whole gut transit study. Pill cam, it's to evaluate the small intestine. Typically, this is done for anemia to see if there's some kind of bleed in the small intestine. What we're looking at in the upper left corner is the endoflip, or the balloon distension study. This is the one we talked about where a balloon catheter goes down during the endoscopy. This is where they're measuring the diameter of the esophagus. There's also there is a motility component to this as well, but specifically we use it to find and measure the LES, lower esophageal sphincter. In the middle is the Bravo pH monitoring test. This is the one that tells us, do you have reflux, and what is the severity, and what is your pattern, daytime, nighttime. So the blue line running across the top is supine, so that's when you told us you were sleeping. The green that you can see there marked is when you were eating or drinking, and then there are little diamonds running across that, actually when you pushed buttons telling us you felt something. So there's a tiny blue line a little bit further down the middle of the page, kind of where you see all these numbers sitting there. Any red below that is reflux. And so when I'm looking at this one, this is a significantly positive study for distal esophageal acid reflux and a bipositional, both upright and supine position, or daytime, nighttime. On the right hand of the screen is a timed barium swallow. So again, this is just that easy test that doesn't require any balloons or catheters, needles, anything. So this is just drinking that barium, chalky type substance, and then them simply taking a picture. So this is the esophagus. On the bottom of this slide, this is high resolution manometry. The upper portion is your upper esophageal sphincter in your throat. The one at the bottom is your lower esophageal sphincter, and the ski slope looking thing is your esophagus itself, and then below all of it is your stomach. So what I'm looking at is relaxation of your valves, and then also the peristalsis, or the squeeze of the esophagus. So the first slide on the left is a normal swallow with nice relaxation of the upper and lower esophageal sphincter. The next three are essentially abnormal findings. So the second one, where you see the large red blob, as I call it, is jackhammer esophagus, or nutcracker esophagus, which can be found with people who have atypical chest pain. So typically they've been to the emergency room and had a cardiac evaluation and it's been negative, so they get sent to us, and it is oftentimes we will find this. So it's actually called hypercontractile esophagus, also known as jackhammer esophagus, and used to be called nutcracker esophagus. The third image in is essentially absent contractility. So if you compare it to the first one, there is no ski slope, and under the lower imaging there are dots, which also tells me this person has a hiatal hernia. So that would be an abnormal finding as well. And then the fourth and last one there is actually the achalasia that I talked about in this time barium swallow. So this is essentially, like I said, opposite of reflux. The lower esophageal sphincter is not relaxing, and so there is this big red blob, and there are 3 different types. So eventually the first one you'll see this, the second one it'll just kind of be straight up and down, and then the third one it's just a straight consistent line across that identifies that the lower esophageal sphincter is not relaxing, whereas in the first one you can see that there is green and then it relaxes and you see light blue and then it goes back to the green and yellow. After your comprehensive reflux evaluation is complete, we have you return for a follow-up visit. That can be in person or Zoom or telephone. We would go over the charts, graphs, numbers, pictures, and discuss the results. You know, when we're reviewing the results, we see, you know, one, do you actually have reflux? What's your pattern? What's the severity of it? So if you're someone who opts for medical therapy, is it once a day, twice a day? How are they taken, along with diet modification and avoiding triggering foods and chemicals such as caffeine, alcohol, and nicotine. Then again, and all of these results are based on diagnostics. So the motility study that we talked about, kind of based on the performance of your esophagus. We can discuss endoscopic and surgical interventions. If you're someone who has never been on a medication, I kind of compare this as orthopedics. Reflux is no different. So, you know, you come in, your knee hurts, I'm going to tell you to ice, rest, elevate. Next, we'll do ibuprofen, you know, medical therapy, so ibuprofen, Tylenol. You know, if it continues, we might do some injections, and then eventually you might need a surgery. So reflux is no different. We kind of go through those steps as well. If you're somebody who's never been on a medication, that's certainly, we want to do a trial of that, and a lot of people do well on medications, and we continue to monitor you. I kind of tease and say you get put on my Christmas list once we know you have reflux. You're either, you know, annual, you know, every 2 to 3 years or every 3 to 5 years, and, you know, and sometimes on as needed basis. So we're going to keep an eye on you. We're here to prevent esophageal cancer. That's our goal, and to make sure your quality of life is good. It's often that people will be on, you know, once a day and go to twice a day medical therapy, and then continue to have breakthrough symptoms. When we talk about reflux, it's really about a valve that's not working, the lower esophageal sphincter, it's weak. So again, it isn't fixing, medication isn't fixing the problem, but it's helping the symptoms of it. So people will oftentimes say, well, the pills help with the burning sensation, but I still have stuff coming up. I have a sore throat, cough, voice hoarseness, all those types of things. And so that's when we talk about moving to the next options, whether that's endoscopic or surgical intervention. This is a lifelong disease, as we discussed, so we are here for you.
Hi, my name is Gina Shimmick. I'm a dietitian at the Minnesota Reflux and Heartburn Center. Today we're going to discuss diet and lifestyle modifications for acid reflux. There are a couple of non-medical ways to treat symptoms of acid reflux through diet and lifestyle modifications. One of the first things we can work on is weight loss, especially for those with a BMI over 30. This can help reduce symptoms of acid reflux by lessening the pressure on the abdomen. We can also discuss how to avoid foods that can trigger flare-ups of acid reflux and what appropriate substitutes in your diet would be. The foods you see listed here are commonly associated with acid reflux. Other diet modifications include eating multiple small meals per day versus 3 large meals to reduce pressure on the stomach and not eating too close to bedtime.
Hi, my name is Megan Perpich, and I'm a registered dietitian here at the Minnesota Reflux and Heartburn Center. Together, we would work on non-medical treatment options through diet and lifestyle modifications to help relieve your acid reflux symptoms.
The lifestyle modifications we would discuss include smoking cessation,
We would talk about ways to reduce stress, such as eating in a calm, stress-free environment, which helps eat more slowly, staying upright while eating and after meals, elevate your bed at night when you sleep. You can do this by using blocks to prop your head 6 to 8 inches or by using a medical bed. Note that propping a pillow is not recommended and pillow wedges are discouraged. We would talk about wearing loose-fitting clothes to avoid additional pressure on your abdomen, and lastly, work to incorporate or continue with regular exercise. This can also help you achieve a healthy weight loss or weight maintenance. If you find that non-medical treatment options do not help relieve your acid reflux symptoms, continue to work with your specialist to further develop a plan for you.
Hello, I'm Dr. Tim Lemire. I'm a general surgeon at the Minnesota Reflux and Heartburn Center, and today I'll be talking to you about acid suppression. Medical treatment options. This includes acid suppression. They either buffer or they decrease the acid production. Antacids are buffers that neutralize, coat, and soothe your stomach. These include things like Maalox, Mylanta, and Tums. This can also have an effect on the reflux or heartburn you may be feeling. H2 blockers are medications that reduce the acid production, but these can be 60% ineffective in some patients. H2 blockers include drugs like Zantac, which is currently off the market, and we do not recommend using it at this time, Pepcid, and Tagamet. None of these drugs stop the reflux. They only buffer or decrease the acid. Acid suppression is a complete reduction in acid production. These include PPIs or proton pump inhibitors. These reduce acid production by completely blocking the acid pump in your stomach so there's no acid production to cause the reflux. These include drugs like Prilosec, Prevacid, Protonix, Asifex, Nexium, and Dexilant. All of these work by the same mechanism, but changes in these drugs per patient are based on insurance coverage and side effects.
Hi, my name is Dr. Sean Roberts, and I'm one of the general surgeons and foregut surgeons here at the Minnesota Reflux and Heartburn Center. Today I'm going to be talking with you about what happens after you've completed your initial workup and what are the different medical therapies for you. The problem with taking these medications your whole life is that acid suppression can have other things. Probably the biggest thing is that people develop breakthrough symptoms. So while you're taking medications, you might be taking it once a day, but get breakthrough symptoms in the afternoon or evening. Some of those breakthrough symptoms require taking a second dose or, again, adding an additional therapy. As you can see, some people will require taking additional medications fairly frequently, several times a week even. And again, as we approach double dose therapy or adding additional therapies, that's when we start talking about failure of medical management. What we also know about reflux medications is they don't stop reflux. So they are heartburn medications and they can help the symptoms. They typically decrease the amount of acid that is produced in the stomach. And so the content that is coming up from the stomach into the esophagus is not as acidic, and so a lot of times they help with symptoms, but they don't actually stop anybody from refluxing. They just change what the reflux is, so they mask the symptoms. And again, most of these medications, as they were trialed and did FDA approval, they were approved for up to a couple of weeks, and most of the time the package insert will say that. So they were never really designed or indicated for long-term, lifelong use. We do see people that are on these medications for years and sometimes even decades, but we do always have those conversations with people about some of the long-term side effects that lead to being on these medications long periods of time. We do sometimes see disease progression despite being on medication, so it is important any kind of change in symptoms or sometimes just routine follow-up is indicated for people on lifelong medical therapy to make sure that we are not disguising precancerous changes or certainly esophagus cancer. PPIs do have some risk. Acid does play a role in your body, and it changes how some elements are absorbed, such as calcium, and so sometimes we can see osteoporosis associated with that. We mentioned dependency, which means that you just need more and more of the medications over a period of time. Certain vitamins are also not absorbed as well, so we will see deficiencies of some of these minerals, iron and magnesium as well. That can lead to electrolyte abnormalities and cause actually heart rhythm problems, usually related to low magnesium. Chronic diarrhea, sometimes seen with PPIs in particular, and changes in the makeup of the colon bacteria can sometimes lead to Clostridium difficile infection, which is a fairly significant and sometimes severe cause of chronic diarrhea in patients. We will see kidney troubles with the PPIs in particular as well, reaction with various types of medications that you might be on, increased infection risk, particularly for hospitalized patients associated with PPI use. And there's even been some association with dementia and stroke. So these are all conversations that we have with people, and that's part of the individualized therapy that needs to be done. When we start looking at your test results and looking at the various medical options, trying to determine what the best option is, evaluating the safety profile of these medications, and I always try to get people on the least possible effective dose that manages the symptoms when we're talking about sticking with medical treatment.
Today I'll be talking to you about the incisionless, minimally invasive procedure called the Strata procedure. The Strata procedure is a minimally invasive treatment for reflux disease. It is incisionless and it is delivered through the mouth down into the stomach. The Strata procedure is an outpatient procedure and there are no incisions. We use conscious sedation or general anesthesia depending on the patient. The procedure lasts approximately 1 hour and you go home the same day of the procedure. Most patients return to normal activities the next day. It is much less costly than open surgery and much less expensive than a lifetime of medications. It is a good, safe alternative for high-risk patients as well. The Strata Catheter is flexible. It has a soft, rubbery tip. It monitors temperature and impedance during the procedure itself. It has irrigation and suction, and we place it over a guide wire. The catheter is connected to a computer module that monitors the temperature and automates the radio frequency delivery and automates the shutoff. This picture shows the Strata catheter in place at that lower esophageal sphincter, or some people call it the flapper valve. With a balloon inflated, these tiny needles come out into the muscle, and a treatment zone is completed at 1 of 6 levels. The computer heats up these needles and is automatically shut off at the proper time, and afterwards these muscles will thicken or become hypertrophic, and that causes that valve to get thicker and reduce your acid reflux disease. The procedure can be summarized by placement of the catheter, treating multiple sites of the lower esophageal sphincter or that flapper valve that causes the reflux. Heating these up increases the thickness of the muscle and augments the barrier to reflux. Results show a significant percentage of patients are able to discontinue their medications and all heartburn meds. Improvements in heartburn and good patient satisfaction with regard to reflux. Esophagitis resolved in 74% of the patients. Regurgitation is eliminated in about half of patients. No significant adverse effects. Results improve over time out to 12 months, and repeat procedures may be performed if necessary.
I'd like to speak to you about Transoral Incisionless Fundoplication, or Tiff. This is a newer procedure that's been introduced because it's purely endoscopic, meaning there's no incisions. It is performed with an endoscope and not laparoscopy. So there are absolutely no surgical procedures in the abdomen whatsoever. In this operation, as seen in the diagram on the right, the top of the stomach, the fundus, is actually folded up and secured around the lower esophageal sphincter muscle to support the reflux barrier. The way that it's fastened is with H fasteners, little plastic fasteners that are placed through the wall of the esophagus and through the wall of the stomach. and actually they're quite strong. This simulates the toupee partial fundoplication because it's a 270-degree wrap. This procedure is performed same day. Everybody goes home. The end of the day, we use a general anesthetic in the operating room. The advantages of this is that there is no reported gas bloating after the procedure, except perhaps in the first few weeks. Same thing for swallowing. Swallowing difficulties are not described long-term, only in the first week or two following the procedure. You will be given a progressive liquid diet, which is very important to follow over the first few weeks while it's healing. Now, the challenges can be if there's a hiatal hernia, it really can't be used. We do prefer a laparoscopic approach in that case, but we can do very small hiatal hernias with this technique. It can't be used if the Gerd complications are advanced. In other words, if there's Barrett's esophagus or severe esophagitis or evidence of destruction of the lower esophageal sphincter mechanism. And the other problem is it's relatively new, so it may not get insurance coverage. If we look at the next slide, this is a pictorial where we can see the cutaway stomach, and we can see the device which has been inserted through the mouth and down into the stomach with the endoscope inserted through the middle of the device in order to monitor and perform the procedure. And what we're trying to do here is take a person with Gerd who has a fundus that is not up against the lower esophageal sphincter, and we're using this device in order to approximate the fundus to the lower esophageal sphincter. In these diagrams, we are able to see that the device, after pulling the fundus down in, fires these little H fasteners. We fire about 20 of them, and here's a picture of what it looks like afterwards. A beautiful nipple-like valve created that stops reflux. This slide demonstrates the longevity and success, long-term success of the procedure. This is a European study with 10-year durability, and we can see with the patients, whether it's the quality of life, the degree of heartburn, or the degree of regurgitation, that after 5 years, it remains stable through 7 years and even 10 years. Final thought on Tiff is the exciting development in our center of being able to have this new tool to be able to repair and fix old Nissen fundoplications and toupee fundoplications that have loosened and reflux may return after weakening of the stomach. But here's pictures, the one on the left with a failed Nissen. You can see the opening is now loosened here next to the scope. And a Tiff procedure has been performed to actually tighten this back up again. No surgery, no revisional operation. And on the right, here, toupee procedure, and again, a beautiful valve that's able to be recreated to give this patient many more years of Gerd-free symptoms. This is looking very good. The subjective outcomes show 90% of the people off their medications again, and the side effects don't show any significant swallowing difficulties, bloating, or flatulence. So this is an exciting new development for the future. The Lynx magnetic sphincter augmentation procedure is another that's offered at the Minnesota Reflux and Heartburn Center. We've been involved with the Lynx very early on and have performed some of the research and the development as well. The advantages of this particular technique is that in the earlier disease process, we can place a magnetic bracelet around the lower esophageal sphincter done laparoscopically. And these are rare earth magnets coated with titanium into a bracelet that opens up, as in the lower picture, where the food is being passed through the bracelet and into the stomach. As soon as the food arrives in the stomach, the magnets attract one another and it helps reinforce and augment the lower esophageal sphincter by closing, therefore keeping the acid out of the esophagus. This is a minimally invasive laparoscopic procedure, again allowing same-day discharge to home like many of our procedures. There's no alteration of the top of the stomach, as in fundoplications. which allows patients to retain the ability to belch and to vomit. There's reduced gas and bloating symptoms as compared to fundoplications. It is removable by laparoscopic technique. However, that might not be good because removable means there might have been problems. And in fact, when we look at the challenges associated with Lynx, we do see that there is certainly transient difficulty in swallowing as scarring takes place around the beads over the first few weeks and months. Eventually, in most patients, they're able to swallow just fine. However, there can be certain patients who have intolerance due to excessive scarring. And with that, the explants, in other words, the removal of the device, has been increasing throughout the world over the first 10 years. Initially, it was reported to be about 3.5%, but in the most recent study from Dr. Bonavina in Italy, it's up to 9%. So that should be a consideration that your specialist would discuss with you should you be interested in a Lynx. The device erosion is very, very small and is not considered a negative for implanting a Lynx because it's so rare. There is a problem with getting a high-resolution MRI scan, and it's limited to the 1.5 Tesla scans, but that does represent about 80% of the scanners in the country. So most people are able to still get an MRI, just not high resolution. And again, insurance coverage for this relatively newcomer to the anti-reflux surgical armamentarium, it is difficult even after 10 years.
We're going to talk today a little bit about some of the surgical options for the treatment of reflux disease. Many of the surgical options for treatment of reflux disease revolve around reinforcing or augmenting that lower esophageal sphincter. We don't necessarily need to tighten it up, but we want to prevent it from loosening. The gold standard for the treatment of reflux disease has always been Nissen fundoplication. As you can see in the graphic here, that's a complete wrap where we use the stomach to actually reinforce that lower esophageal sphincter. In cases where the esophagus does not necessarily have as much power to move things through, we may resort to a partial fundoplication, also known as a toupee fundoplication, in order to achieve the same result. That is, reinforcing the lower esophageal sphincter and preventing reflux from occurring, while not impairing the patient's ability to swallow or belch. Most of the surgical options for treating reflux disease over the last 50 years have revolved around finding ways to stop the reflux with a minimum of potential side effects. That's what toupee fundoplication is about, as well as some of the other options that will be presented later in this talk.
What we're going to do today is talk with you about one of the surgical options called the gastric exclusion. So if you've been watching the video series, you may have heard about some of the other operations that we do, the fundoplication, the Tiff, the Lynx, different surgeries that are available. Part of the comprehensive reflux evaluation is looking at all your information and deciding what operation is going to work best for you. And this is one of the surgeries that people often end up choosing along with their surgeon, depending upon some of the factors that come up in their workup. We discovered that this is a good reflux operation a little bit by accident because we are also a bariatric or weight loss center. And so we do a lot of gastric exclusions. Of course, in that setting, we call that a gastric bypass. And that's one of the operations that's done for weight loss. But what we discovered over the years is that oftentimes as we were seeing people in the clinic in follow-up after their weight loss surgery, we realized in discussing things with them that we were curing a lot of reflux along the way. Also, as we'd done operations such as fundoplication, the Nissen or the toupee, and people needing revisions, sometimes the revision ultimately ended up as a gastric bypass as a therapy. And so we started using it as a revision operation as well. This has become more of a standard operation now for people who have an elevated BMI. And what we learned over the years also is that some people are not a good candidate for a Tiff or a fundoplication or a Lynx because of their BMI. Typically a cutoff for that is a BMI more than 30, but it typically also depends a little bit on your body distribution. People that have a BMI more than 35 are really not very good candidates for fundoplication or Lynx because of the increased abdominal pressure on their abdomen, pushing that hernia repair, causing stress on that or causing stress on the fundoplication and contributing to increased reflux. So the Roux-en-Y gastric bypass or the gastric exclusion ends up being a therapy for that. So with the gastric exclusion, what we're really doing is disconnecting the source of the acid from the esophagus. When we do a gastric bypass, the first part of the gastric bypass is dividing the stomach into an upper pouch, which ends up being about the size of a golf ball, and then the lower part of your stomach, which of course excludes 90+% of the acid, and that acid ends up going downstream through the small intestine instead of going up into the esophagus. Of course, we can't just leave a blind pouch near the esophagus, so we bring up a loop of small bowel, and that loop of small bowel is called a Roux limb, based on the surgeon that first described it. And once we connect that, then we reconnect the small intestine a little bit lower, and that's what creates that Y configuration. That's why it's named the Roux-en-Y gastric bypass. But what that does is it shifts all the acid downstream, and that acid then isn't in contact with your esophagus, and thus it's an excellent operation for people that have gastroesophageal reflux disease and also have a high BMI, or it also ends up being a revisional type operation for people that have several failed primary operations. The nice thing about this is oftentimes people that have an elevated BMI also have numerous medical comorbidities, and comorbidities are disease processes that go along with being overweight, such as type 2 diabetes, high cholesterol, and hypertension. So sometimes it's the best solution for people that have elevated BMI and multiple comorbidities along with gastroesophageal reflux disease. So this is part of why we go through this comprehensive reflux evaluation, because everybody's a little bit different, and what we're trying to do is tailor the operation to what is best for you overall. Some of the challenges or things that we have to think about after this surgery are vitamin and mineral supplementation. There's some education that goes along with it because obviously you have to eat a little bit differently, and so we go through that educational process as well.
Today I'll be talking to you about robotic surgery as it applies to gastroesophageal reflux disease. The Minnesota Reflux and Heartburn Center is proud to offer robotic-assisted anti-reflux procedures. The Da Vinci robot is one of the newest technological advances in general surgery. It allows for the surgeon to see through a 3D view that allows for better depth perception and manipulation of tissue. Wristed instruments are used to increase surgeon dexterity. Perhaps the biggest factor is surgeon autonomy. In traditional laparoscopic surgery, we work with an assistant, a camera holder, and of course the surgeon themselves. During robotic surgery, we're able to control all of that ourselves as a surgeon, which sometimes allows us to be more facile with our instruments. To this point, data suggests equivalent outcomes to the laparoscopic approach, and ultimately the approach of the surgery will depend on surgeon and patient preference.
If you have arrived at the conclusion that you might be suffering from Gerd or swallowing difficulties, we encourage you to investigate and consider a comprehensive evaluation as described in this informational video series. And when you do, why should you come to the Minnesota Reflux and Heartburn Center? Several reasons. We have an experienced team of experts dedicated to helping you find the best solutions tailored to you. You'll have an amazing nurse navigator assisting you all the way, a truly concierge level of personal services. We have the most comprehensive diagnostic GI lab in the region. Our specialists offer all treatment options: endoscopic, minimally invasive, revisional, robotic, and bariatric solutions. Our center has long been dedicated to professional education, training more than 50 surgeons and 15 fellows. We're leaders in cutting-edge research nationally. So we encourage you to call one of our nurse coordinators to get started. The Minnesota Reflux and Heartburn Center may be just right for you.